Am I audible? Good afternoon, everyone. pCoE MCH welcomes all the participants for today's RDLS session. Today's topic is screening and diagnosis of TB in children living with HIV, and the speaker is Dr. Kalpana Datta. Dr. Kalpana Datta, ma'am, is the program director for the Pediatric Center of Excellence in HIV Care and the professor and head of department with the Department of Pediatrics at the Medical College Hospital, Kolkata. She is also the in charge of the adolescent clinic at MCH. She is a national trainer for malnutrition, pediatric HIV, early child development, and NTP. She has authored numerous papers published in both international and national journals. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Ms. Cheta, for your kind words. Good afternoon, everyone. Myself, Kalpana Datta. Today, I'll be talking on screening and diagnosis of tuberculosis in children living with HIV. Am I audible clearly?
Yes, ma'am.
So, in this session, we'll be discussing the status of childhood TB as per India TB report 2024, so that we can have an idea what is the burden of the disease and where we are at fault and where to we have to improve ourselves as a programmatic issues. Screening for tuberculosis in children living with HIV. How will you screen tuberculosis in children living with HIV? Our diagnostic algorithm will be discussing, and challenges faced while diagnosing the TB in children, because it can mimic many diseases. Diagnosis of different types of tuberculosis in children living with HIV. There will be some case scenarios. If time permits, we'll discuss all the case scenarios in detail. So if you go for the burden of the disease, that the end TB targets and achievements for India. Its targets is by 2025 and 5 years. We know sustainable developmental goal, the timeline is 2030. So the target is fixed by government of India, this 2025. 80% reduction in the TB incidence rate. If you consider the number of patients in 2015 to 2023, we'll go in details. So there's a reduction of 80%. And 90% reduction in the mortality. So we can achieve a bit better in the mortality to reduce the mortality in children. Zero TB affected households suffering from catastrophic expenses due to TB. Means any adult is suffering from TB, and then the household contact should have been given the prophylaxis, and there's no infection in the household contact. That should have been achieved by zero. So if you see the impact of indicators, what was the baseline and what we have achieved and what we have to achieve by 2025. So to reduce the estimated TB incidence rate is from 2017 to it should have been 77, but we have achieved 199. We are far behind the target. To reduce the estimated mortality due to TB, that is the baseline was 32, target was 6, and we have not achieved so much as 23. To ensure that number of families should suffer from catastrophic cost due to TB, it's a 35% was there in 2015, which should have been achieved as a zero, no catastrophe in the family, and the data is not available for that. So WHO information sheet, that is the roadmap towards the ending TB in children and adolescents. So 10.6 million patients in 2022, out of which 1.25 millions that contribute about the 12% of the TB patients by the children, that is 1 to 14 years. And death is 1.3 million, out of which 2,14,000 were death contributed by children. So if you see the less than 5 years, the maximum death is a 47%, and the 5 to 14 years is rest of the death was there. And 7,27,000 adolescents are contributing for these indicators. Then if you see the among the death in HIV related patients, the children were young, less than 14 years, that is 76% were in the less than 5 years. So without HIV, it is 47%, with HIV, it is 76%. And the 96% death occurred in who did not have the TB, who did not have received the TB. So no treatment, then the you get is equivalent to 100%. It means 96% are died who did not have any treatment for that. And 31,000 TB death in 14 years group were among the children living with the HIV. So 31,000 cases, rest of the percentage. So that contribute to the 14% of the total death. The treatment coverage gap remains highest among the youngest children. Why so? If you see this bar chart and from the percentage of missing person with TB in different age groups, you just see the right one, the most right one, that is the all more than 15 years. From that right to left, if you go there, you see they're under 4 years. So maximum missed in the under 4 years. So as you go towards the younger age group, the chances of missing or reporting is quite high. Only 42% are reported, and 50 we have missed the 58%. That may be the wrong diagnosis, that may, or maybe the diagnosed but not reported on. But as you increase the incidences are decreasing, because then it's easy to identify the TB patients, and more concern and more the programs are more emphasized on the older age group. So the more and more reported cases with there. So there's a huge gap in the detection in the under 5 age group. So 58% gap is there. Now, childhood TB as per Indian TB report is 2024 report. Annually, at least 5 to 7% of all TB patients are notified under NTP are children, contrasting the expected 10 to 12%. So it should have been 12% reported cases, but just less than 50% we have reported till now. That's a 5 to 7%. Pediatric TB notification in 2023 under 14 is, that is about 1.4 lakh pediatric TB patients. Pulmonary TB is more prevalent than extrapulmonary TB has been seen. But in case of HIV, we expect more cases of extrapulmonary TB than the pulmonary TB. As per next day data, APTB cases in the pediatric age group is 44%. And DRTB, that is more dangerous things now coming up. Pediatric DRTB, we are getting the more patients. That's the notification in 2023. 2,108 MDR-TB, that's resistance, that's rifampicin resistant TB cases were there, and 348 is mono or polypediatric DR-TB patients were diagnosed. Mono means either INH or poly more than INH, or rifampicin or drug resistant TB patients were diagnosed. So why a huge gap in detection of TB in children? Often underdiagnosed and underreported due to lack of simple sensitive point of care test. We know it is very difficult to get the sputum, very difficult, because they are possibly they don't have the bacilli in this sputum, so detection is less. Sometimes they cannot expect to at a younger age. So lots of problems are there in the children, so they are underdiagnosed. And if diagnosed at all, it is not reported, so underreported also. TB control strategy not so well equipped for the diagnosis of TB among children. Program is organized with the adult cases. Whenever there is the policy making and all, they everything is oriented towards the adult. Then they extrapolate the data from the adult and they try to fit in the pediatric age group. So childhood TB action thus often need to retrofit into the mold already set for adults. So we have to readjust, remodify the program so that we can include the children. But there's no dedicated children programs for this. Differences in the disease and its diagnosis among adult and children creates a divide, because bacteria is what quite more in to radiology in adult than if you compare to the radiology more versus the bacteriology. We don't get the bacteria. We cannot demonstrate the bacteria sometimes, or it is a possibility. So there are difference both in the presentation, identification, and diagnosis. So there's a gap. Chest X-ray interpretation is difficult with the presence of other HIV-related conditions, because whatever the typical findings we get in tuberculosis, like the pulmonary highland lymphadenopathy, fibrocageous type of tuberculosis, or miliary mottling, you can get the miliary mottling with the LIPs. You can get the, it can mimic the bronchiectasis also. So there is a lot of confusion while having the typical pictures radiologically in pediatric age group. HIV-infected patients with active TB proven on sputum culture can have seemingly normal chest radiograph. That is the crux of the disease, because you can get the chest X-ray which is normal, but sometimes you might get the positive, sputum positive, because in X-ray we can see the not only the deep structures can be picked up, sometimes we do get by in CT and all, but it is not possible to do the CT scan in all the cases. Moreover, chances of radiation quite high if you go for the CT. Microbiological test, sputum microscopy has a poor sensitivity in detecting TB in patients with people living with HIV due to fewer organisms sputum. Microbiology. Moreover, the children, they don't expectorate the sputum. even though they can produce the sputum, the tacit force, that the force which needs to evacuate from the bronchus to the mouth is very weak. So they cannot expect it out from the deep in the alveolus to the bronchus to the sputum. So they and it is usually a possibly. Moreover, it is usually lymph node TB sometimes, and there's no connecting bronchial bronchus. So it may not have a organism within the sputum. Nucleic acid amplification test, the frontline test for diagnosis TB amongst children living with HIV, that is the only we have in our hand. If NAT is not available, then what to do? Arrangements have to be made to collect and transfer the specimen to the nearest center where NAT can be done, or MGIT, that is the microbacterial growth indicator tube for the liquid culture, we have to send it. So there are some issues for which can contribute the detection of gap in children with HIV. Tuberculosis in children living with HIV has a myriad of presentations. TB in children is direct consequence of adult TB. So whenever they come, the children come in contact with the adult patients suffering from TB, they can have a disease. So it is a marker of transmission in the community, because the childhood TB, they don't transmit the disease. Why so? Because the parenchymal disease is not that common. The lymph node TB is common. And moreover, if the parenchymal TB with the communicating with the bronchus, then only there will be chances of coming out the bacilli. Then, as I've already said, the tacit force needed to take out from the lesion to the bronchus to the sputum, and then they don't spectorate. And if even though they expectorate, they used to swallow the sputum. So it's very difficult to get the disease. So they don't transmit usually. But adult TB, they can transmit. So if the child, more and more children are having tuberculosis, that gives the marker transmission in the community. Children living with HIV are increased risk for developing TB, because both are immunocompromised, and there is a same pathway. HIV helps to proliferate the tuberculosis bacilli. Tuberculosis bacilli helps to propagate and multiply the HIV virus. So both goes in synonymously, and one disease can precipitate other disease severely. TB and HIV can present a similar symptoms in children, leading to delayed or misdiagnosis. HIV can present with like a severe malnutrition, pneumonia, diarrhea, prolonged fever. Similarly, TB patient can have a malnutrition, pneumonia, diarrhea. So it's very difficult to differentiate these symptoms are due to HIV or due to other disease like tuberculosis. Rates of drug resistant TB tends to be higher in children HIV, because we are getting the drug resistant TB nowadays, and there's no fixed protocol. Some drugs are not indicated below 6 years, and all because of the lack of the reliability and the confirmation. Other different drugs acting in a childhood TB, resistant TB is not there. Recurrent disease and relapse more frequent in the child with HIV. So the children who are having HIV and they will have a recurrent tuberculosis, there can be relapse. It can be more complicated, more severe form, and can have a more extrapulmonary tuberculosis, which can increase the morbidity and mortality in the children. So they infected CLHIV have an increased risk, because primary progressive disease, TB disease, primary disease is when there is a only primary complaints, that is the primary focus, draining lymphangitis and catchment area lymphadenitis. But when it progresses to pneumonia, emphysema, obstruction, consolidation, and or bronchopneumonia and all, that is called primary progressive TB, which is more common with the children. Extrapulmonary TB, other than lungs, it can involve the pleura, it can involve the gut, it can the CNS TB is quite common in HIV children. Drug resistant TB, again we are getting more cases of drug resistant TB, and higher case fatality. It is the morbidity. So diagnosing TB in children is a history and examination. Then is the highlighter now? Okay. Sorry, I'm setting the pointer. I'm not getting the pointer. Pointer option. Put arrow. Okay. So not getting. Okay, forget it. So history examination, then the Radiology and bacteriology will go side by side. So thorough history is to be taken, head to toe examinations, systemic examinations. Then we'll go for the radiology and bacteriology. So what is the approach in case of children living with HIV for tuberculosis? First, we'll go for the 4S screening, and if there's a 4S screening is positive, then we'll go with careful. So for that, we need to have a careful history. So 4S, actually this is mainly focus on the pulmonary TB. That is in this 4S, it is not included like recurrent pain abdomen, altered bowel habit, chronic diarrhea, enlargement and lymph node. That may be the presentation of tuberculosis, but it doesn't come under the 4S heading. So you have to take the 4S in each and every visit. Along with that, you have to take the detailed history. Then I will go the clinical examination from head to toe examination, not only head to toe, systemic examination means the respiratory tract examination, GI examinations, musculoskeletal examination, neurological examination. So we can get any the tuberculosis in any other site. Then if there's any difficulty in the ART center and all, because they are not expert in pediatric patients or they are not pediatric specialists, you can always take the opinion of pediatric specialist wherever it is feasible. Then I'll always try to confirm it by microbiology. So bacteriological confirmation, whenever possible, don't keep any stone unturned to get the sample and get tested for the microbacteria. If VHC patient comes with the meningitis, like we had a patient of tuberculosis meningitis, but we diagnosed it by the gastric lavage. CSF was negative, and we did the gastric lavage. So you have to do the other possible resources where you get the sample and test it for the bacteriology. Then of course radiological investigation can help, like we know in case of pulmonary TB, as I've already said, pulmonary tuberculosis, hilar lymphadenopathy is one is a very good suggestive of tuberculosis, fibrocageous type of tuberculosis, miliary mottling, one of the disease. Similarly, in case of CNS TB, if unexplained hydrocephalus, basal meningitis, there is a unexplained stroke, it should be TB should be one of the defenses and it first come first. So radiology sometimes helps in the diagnosis also. Then other investigations relevant to the suspected PTB, like in a lymph node, you have to go to FNAC. If there's no result in FNAC, you can go for the external biopsy, sometimes USG abdomen. You can go the, recently we have got one patient of abdominal tuberculosis by omental biopsy. USG normal and the stool are all examination. CT, when CT was normal, then we went for the omental biopsy and it was diagnosed. So any resources, any clues you get for the getting the investigations, I have to go for the investigation to prove it as a bacteriological confirm. Because if you get the bacteriological confirmation, you'll be able to know whether there's a patient resistance or monoresistance or polyresistance, MDR or XDR TB. So what are the clinical features in pulmonary TB? It may be fever, cough, failure to thrive, weight loss. Not only weight loss, not gaining weight necessarily, again, important in pediatric patients. Loss of more than 5% body weight as compared to the highest weight record in the last 3 months. So in the first consecutive 3 months, you have to see the weight loss. Is any month there's a more than 5% weight loss, you should consider as a weight loss. Or there's a static weight, baby is not gaining weight, because this is a constant growth phase. Baby is constantly gaining weight. So any arrest in the growth, always think is one of the for symptom for pulmonary TB. Then contact with the TB cases. Contact with a person with any form of active TB within the last 2 years. And there's one question I received from some audience. Madam, can tuberculoma in the brain is infectious? Because tuberculoma is not an infectious thing. It is a one is a closed one in the brain. How come it will be? How can you take the contact of TB positive in that particular case? Because the definition is given because any type, any form of activity, any form. What happens if there's a tuberculoma, that may suggest there is some pulmonary TB. And pulmonary TB in adult, it is contagious. So we take it the contact with the TB cases and any form of active TB is a positive history. Clinical features of extrapulmonary TB, as I already said, in case of lymph node TB, you can have a lymph node enlargement, sinuses, discharging lymph node and all. Headache, in case of CNS TB, you can have a headache, confusion, convulsion, disorientation, and of course, hemiparesis, paraplegia, hemiplegia, cranial pulse, and all those features. Then in joint bone pain, bone TB, that's a post spine, backache, joint pain, spinal deformity. They land up in the orthopedics for the spinal deformity, and that may be a bone TB. Chest pain, again, tightness, chest, respiratory distress, when there's a massive effusion, pleural effusion, or pericarditis, there will be chest pain. But in pericardial effusion, there will be a huge pericardial effusion, that there will be respiratory distress. Abdominal pain, swelling, discomfort, altered bowel habit, persistent diarrhea. This may develop in the case of GITB. And the respiratory distress, it is usually because of the mechanical, because huge ascites can hamper the movement of the diaphragm and can lead to the respiratory distress. And of course, the history of contact TB should be considered. With the HIV, the atypical features are more common, like extrapulmonary TB, miliary TB are common among the young children. Young children present the localized pulmonary infection, the hilar adenopathy. So, if there is a hilar adenopathy and there's a medial consolidation, you must think of your tuberculosis. 25% of children may so involve in the more than one lobe. So, it is not limited to one lobe. It may be more than one lobe, or maybe bronchopneumonic type, this is bilateral involvement. Middle lobe collapse and consolidation may result due to the endobronchial tuberculosis. That's a very characteristic finding. So if you have a middle lobe collapse or consolidation, you must suspect tuberculosis and rule out tuberculosis, then think others. Older children and adolescents may present with the cavity lesions. So for symptoms screening, fever, current cough, poor weight gain, and contact with TB. Again, fever, for the protocol, for the guideline, we have to write something. So we have written fever. But fever may be due to, like in rainy season, it may be due to upper respiratory infection. It may be the gastroenteritis. It may be dengue season. There may be dengue. It may be malaria. So the medical officer was sitting in the ART center must look for the other causes also. So in all cases, some fever, if you go on screening, it will be a huge load, because fever may be, you will see if the baby is a running nose, nasal block, flushed face, having coughing all the time. It is URTA. You don't need to investigate for tuberculosis. If baby is having acute gastroenteritis, vomiting, pain, loose motion, it is gastroenteritis. So from the ART center, you have to look out the causes of fever. If it is not explained by any other causes of acute fever, then of course you consider as a maybe the TB. Of course, poor weight gain is one of the characteristic feature, because acute lesion, infection children won't lead to the weight loss. Like as I said, upper respiratory tract infection, gastroenteritis, and malaria, dengue fever. In 7 days to 2 weeks, there will be no weight loss. So if there's a poor weight gain and weight loss, you think of the TB. Then current cough. Again, current cough is due to what? Because viral infections, upper respiratory infection, the commonest cause of cough. You see it is not there, then you think of the tuberculosis. And of course, contact with TB cases, you have to investigate whether there is a symptomatic or asymptomatic. Fever of any duration, as I said, current cough. So these things are written, but you always look out the other causes, then think of the tuberculosis. Poor weight gain, defined as either one of the following, already discussed, more than 5% body weight, any last 3 months recording, or not gaining weight. Contact with the TB is very important. That should be emphasized, and always take the history, because you know what happened if we ask the history. Is there any history of contact in your family? They'll say नहीं मेरे घर में किसी का नहीं है. But if you say 2 साल के अंदर में कोई दवा खाया है, हाँ एक का हुआ था 6 महीने, वो 1.5 साल पहले खत्म हो गया उनका दवा. Because in pulmonary TB we give for the treatment for 6 months. So parents will think, oh, it is the story of 1.5 years back. Why I should say now? But you have to emphasize any form of TB, either still present or has already taken antitubercular drugs and finished in the last 2 years. That's also to be considered as a contact of TB cases. So fever and all four symptoms are there. Then you rule out the other causes, then think of TB, and you have to investigate. If there's a forest negative, okay, you give the other advices for the baby has come to you, the medicine, the weight according to the medicines, the other, whatever the advice you do give, other cases. If forest symptoms is positive, then it is presumptive TB. So all children of HIV who are presumptive TB cases need further evaluation by the medical officer. Let's discuss with the case. Master A is a 4 years old who presented a cough and fever for 1 month. So long duration cough and fever. It's not 7 days. It's not upper respiratory tract infection. Mind it. His mother completed treatment of pulmonary TB 1 year ago. See, the mother has already completed. No more infections maybe, but it is by definition within 2 years. So you should take as a history of contact positive. On examination, weight is 13 kg. So 4 years, it should have been okay. It should be 16, but 13 some weight low, but weight is less than the age, 4 years. Height is 95 centimeter, a bit low. It should have been 100 centimeter. And there is a oral candidiasis. So stage 3. Cervical lymphadenopathy is there, liver 3. Now the problem is that because of the whether baby is responding with the treatment, whether he is on treatment, is this a failure of the HIV or cervical lymphadenopathy, hepatitis pneumonia, maybe due to HIV or maybe due to tuberculosis. So it is mimicking, and that's why we used to miss the diagnosis sometimes. You see, respiratory rate is normal, chest clinically clear. So there's no, but there's a lymph node in the neck and liver and spleen, the gut. So there, the dissemination, if you think so. What is the forest screening in this child? Anyone? Please write in the chat box, or you can say, how do we proceed to evaluate TB in this case? So, forest screening is there, fever, cough, and the history of contact. 3 things is there yet to get the weight loss or not getting weight. 3 things in there in the forest. On examination also there is a hepatitis megaly and cervical lymphadenopathy. So when we say the lymphadenopathy is more than 1 centimeter, and when we say the persistent, when it persists for more than 3 months and more than 2 consecutive areas, if there's a gland is enlarged, then we say generalized. So look for the other part of the body whether lymph nodes are there or not. And then next question, how do we proceed to evaluate the TB in this case? So always, as there were oral candidates and all, take the history of odynophagia, difficulty of painful deglutition. So esophageal candidates to be ruled out as a part of this for examination. And cervical lymphadenopathy is there. You see whether it is matted or not, skin is free or is not fixed to the underlying structure, number of the cervical lymph nodes, all those things, as we know, the lymph nodes examination to be done thoroughly. And the investigation here, it is better. The chest is clinically clear, maybe clinically clear, even though we'll go for the chest X-ray. Cervical lymphadenopathy, we'll go with the FNAC, the cervical lymph node. And there's a liver spleen, so we'll go with the USG of abdomen, because if you get any granuloma in the liver or spleen, that may be suggestive of tuberculosis. So forest symptoms there. Now, how to case found for fever, short duration fever, maybe as I've already said, it may be malaria, dengue, upper respiratory infection, viral fever, maybe urinary tract infection, anything. So in the OPD, you're a doctor, you just see what is the cause of fever. The thorough exam, please, and check the head to toe and be systematic. Then presumptive extrapulmonary TB should rule out like lymph nodes, hepatosmegaly, joint swelling, monoarthritis may be the one of the presentation in case of extrapulmonary TB. Chest X-ray, then we'll go for the chest X-ray. So, forest positive, we'll go for the clinical evaluation. And if you suspect in this particular child, we'll go for the pulmonary, presumptive pulmonary TB. In this particular case, presumptive extrapulmonary TB, because lymph node is there and the hepatitis megaly there. Clinically, chest is clear. Maybe there in non-examination, but clinically is clear. So, presumptive extrapulmonary. But if you think of presumptive pulmonary TB, if there would have been any history of cough and all, respiratory cough is, I think cough is there. So we'll go for the chest X-ray, and we'll see the chest X-ray with the characteristic findings are there or not. And in extrapulmonary TB, we'll try to get this sample from where it is possible to get it. So, and we'll go for the chest X-ray, along with we'll go for the sputum. So in this particular case, so 4 years. So the child is not able to expectorate. We cannot expect the sputum that will can collect it from it. So we have to do the either induced sputum or gastric lavage. So for that, you have to admit the patient for temporary admission. You can do it for the sputum, induced sputum, or you can do it in emergency, or if you have an isolated area in your, they can do it there only. The induced sputum and gastric lavage. It is better to admit the patient than do it in the and take the help of pediatricians for getting the gastric lavage. And then you send it for the NAT and see whether microbiologically confirmed TB is there or not. If it is confirmed, then you go with the next algorithm of confirmed TB to give the treatment. Suppose is a NAT is negative and chest X-ray is suggestive of TB. Suggestive means all those 3. That is pulmonary hilar lymphadenopathy, fibrocagious tuberculosis, and miliary mottling. Then you go, it is a clinically diagnosed TB. Chest X-ray is not suggestive. Suppose there is some consolidation. it is just one loop consolidation, lower loop consolidation out. So it is not suggestive, but can be. Go for the antibiotics, give antibiotics, and then ask for repeat X-ray after 2 weeks. Or if the child has already received the antibiotics, then no need to repeat it. And try to diagnose any other disease might be there. But in case of extra pulmonary TB, so here there's, as we have got the lymph node. So you'll get this smear or the FNAC 5 needle aspiration cytology from the lymph node, or sometimes you might go for the biopsy, external biopsy, and send it to the NAT for the NAT in the nearest center. You can go with the cytology and histopathological examinations. So if you have, I don't think ERT center do the FNAC, but you send it FNAC for your pathology or where you can get it. For the NAT, you have to send the sample in a normal saline. But for the cytology and histopathology, you have to send the sample in a formalin. That is to be done. Chest X-ray and other relevant imaging, chest X-ray will do even in extrapulmonary TB. We'll go for the chest X-ray if there's any findings that there or not. Then, of course, like in this particular patients, we'll go for the USG abdomen and we'll see the any paralytic lymph nodes are there. If they're paralytic lymph node and all, or cervical lymph node is so small and paralytic lymph nodes are enlarged, then we can go with the USG guided by FNAC and biopsy. Gastric aspirate should be done less than 3 years of old. 2 early morning sample to be taken for gastric aspirate collected through the nasogastric tube. Admission, admit the patient in the hospital and baby will sleep at night. Early in the morning, before getting up from the bed, you should collect this sample. That's very important because, you know, if baby is awake and start walking and all, so what if the collection the whole night in the gut, it will be moved down. So it is better always before getting up the bed. It is already, we give the instruction to the residents who are on night duty. Early in the morning, they will collect the sample. And it should be, there should not be any visible food materials in the sample. Then it should be discarded. So you have to collect 2 samples and then you send it for the NAT. And in case of induced sputum, when you can do it more than 3 years old, but mature, it actually maturity also counts while doing all those procedures. 2 early morning sample sputum induced within 3% saline nebulization. Here again, first before you have to nebulize the child with a bronchodilator because saline nebulization can cause bronchospasm, baby can develop respiratory distress. So first nebulize with the normal bronchodilators, then nebulize the 3% normal saline. It will instigate the cough and baby will start coughing out and then collect it. So while collecting, this is very important for the medical officers, while collecting the sputum, you must take all the precautions because you are generating AB from the sputum. So you take the precaution for yourself, you know, with all the PP and all. Samples should be at least 2 to 5 ml in volume, and it should be collected in a sterile container after rinsing with the oral cavity with the clean water. So these procedures who collect should be followed. And as soon as you collect, it should be transported to the referral laboratory for the testing as early as possible. So the TB strategic shift in the TB diagnosis, more efficient detection event. Now we are giving more and more emphasis on microbiological diagnosis. Detection of resistance to key drugs by upfront universal drug sensitivity test we do. Because if you get the sample and microbiological test to be done, then only you will realize that maybe this child is sensitive to rifampicin or drug resistance TB. So upfront we'll go on. Previously what we used to do, universal access to rapid test we do. First rifampicin, then you go for the other test. But now universal access to rapid DST for at least rifampicin and further DST for at least fluoroquinones. So we'll go for the further resistance testing for the fluoroquinones, all TB patients. Previously, we don't. Okay, microbiological diagnosis of children. There are hurdles. Microbiological diagnosis in children, there are hurdles. There are hurdles. Children don't expect sputum. So as I already said, pediatric TB is possible slurry. Second points, cannot expect to it whatever expectation they can expect for these to swallow. So this is the hurdles. Culture takes long to grow, and our solutions is, so go for the gastric aspirate, go for the induced sputum, and use the molecular test and use the liquid culture MGIT for the liquid culture. So pulmonary TB sampling is self-expectorated if possible, then collect the sputum. If not, then gastric aspirate into sputum. And if we were in the tertiary care hospital or there's a bronchoscopy facilities available, like in our hospital, we can do the bronchoscopy. So go for the bronchoscopy, the bronchial biopsies, tissue biopsy, USD guided biopsy, can go for that and get the sample for microbiological testing. So ART-MO must look for the extrapulmonary tuberculosis and request for investigation. So not only for a symptom. If for a symptom negative, that does not mean maybe is not suffering from TB. Maybe lymph node TB, maybe gut abdominal TB, maybe the extra pleural effusion, maybe due to CNS TB. So X-ray, we have to examine for the child first, then go for a thorough examination, then go for the X-ray, CT, MRI, depending on the site, organ-specific ultrasonography, and of course the FNAC for that particular area, like pleural aspirates, pericardial aspirate, gastric aspirate, lymph node aspirate, and all. The specimen can be sent for NAT. Sensitivity to NAT for MTB detections is low to moderately high in pus, because pus is a necrotic tissue. Oh no, pus is a necrotic tissue, won't able to get easily not. So moderate to high in pus and aspirate biopsy spin for the lymph nodes, other tissue samples and CSF. So it is better to get the biopsy, but they usually don't get the microbiology in the pus or aspirate. So it is better to have a biopsy, external biopsy or tissue samples. Poor in a pericardial, ascitic, synovial fluid samples, still poorer in a pleural fluid, because these effusions are the allergic manifestations of the tuberculous protein. So it is you don't expect so much bacteria will be there in this effusion. So hardly you do get the NAT positive in pericardial, ascitic, and synovial fluid. A positive result by culture NAT provides useful information. So always go for the culture. Negative culture NAT cannot rule out the TB. That sample is negative. It does not mean there's no TB. So other corroborative findings, other findings of the other part of the body should be looked for. Due to inadequate sensitivity of this test in the external site, we might get the negative result, but it may be TB sometimes. So NTB approved rapid diagnostic tests are, once a child having HIV is diagnosed as a case of DRTB, that's rifampicin resistance or mono-means cyanide resistance on CBNAT or TrueNAT, the first line drugs, you can go with the line progressive. The patient is referred to district TB officer for the further resistance testing. There's the second line LPA, the FL is the first line LPA, and the second line LPA, and initiation appropriate DRTB regime. So it is always better if you have I like to say to medical officers of the ART center, if you face any difficulty, you take the help of district tuberculosis officer. You have DTOs, you have STOs and all. And when we do coordination meeting, there is STAs and the representative from the TB, NTP people, they come. So take the help of them for further investigations and further testing. So on the NAT is the first, which is CBNAT, TrueNAT is yet to be started. First, and the turnaround time is 2 hours. First line probation, you can see it is 72 hours. Liquid culture is to take 2 to 4 weeks. With the liquid culture and liquid DS drag sensitivity, it is further 4 to 6 weeks, and solid culture is a further 84 days. So this is the turnaround time. So if you get the CBNAT and first line LPA, you go for that. So NAT is the frontline test in presumptive TB cases. NAT may be either CBNAT or TrueNAT. A negative NAT does not always rule out TB. Sensitivity and it is sensitive, quite sensitive, especially in particular areas. Increases the case detection preferred diagnostic technique among the patient with the HIV, because other samples we may not get. So at least will be better than the culture. Improve quality of rapid TB diagnosis, because we are getting the result within 2 hours or within 2 to 3 days. Early diagnosis and reduced time taken into treatment initiation can be done, and detection and compensations upfront we are getting. So minimal biosafety requirements, because there's no extra hazard biosafety hazards, and the training needs can be household and non-conventional laboratories for that. And the doctors who are collecting these samples, transporting it, they need some training, and there are some things to be learned. It is there in the website, you can go for that. And there's a minimum biopsy. You should take the precaution of the while collecting the sputum and all in your center. Now, line probe assay, a few words about that. The strip-based molecular test used to rapidly detect MTB within 3 days. It resistance to 80 first-line drugs. Identify the drug resistance by detecting a specific mutation in the bacteria's DNA. LP is performed in a laboratory and is not in a point of care test because you have to send it. Performed directly on a AB smear positive specimen or indirectly on the MTB culture. If it is positive, smear is positive, it's very easy to go for LPA. But if smear is negative, then you have to go for the liquid culture MGIT. That is MGIT test for culture, then isolate, then LPA, and turn around towards 1 to 3 days. First line is the INH rifampicin, second line fluoroquinolones, and second line injectables, amikacin, caprimycin, and all this. So bacterial growth indicator tube MGIT, that is a fully automated system for microbacterial liquid culture and susceptibility testing. So if it's not getting a smear, you have to go for the liquid culture. And it uses MGI tubes which contains liquid broth media and the fluorescence sensor. When microbacteria grow in the tube, they consume oxygen. Depletion of free oxygen results in a fluorescence within the MGI tube. So you can see the color changes in the fluorescence because that oxygen is deprived by, which is utilized by the growing bacteria, and that is the indicator. Intensity of the fluorescence is directly proportional to the extent of oxygen depletion. And quality assured DST is available for rifampicin, INH, pyrazinamide, moxifloxacin, levofloxacin, linezolid, amikacin, kanamycin, and caprimycin. Laboratory turnover time, as already discussed. So flow chart for TB evaluation in children, it is there, you can go for, because in one session is not enough, but if you have to learn it thoroughly, go for the site. It is there in the website, and there is the, I think, link is given in the below. Go for that. Next case, a 3-year-old boy, Master B, newly diagnosed HIV positive, history of cough and low-grade fever since last 3 weeks. So that may be due to HIV, or that may be due to some secondary infections or opportunistic infection. So let's see. Body weight 9 kg, 3 years. It should have been 14 kg. So 9 kg low. CV count is 256. That's 14%. Hemoglobin is all low, 8.81%. Now, is the presumptive TB case? Anyone? Yes, because the fever is there, cough is there. So it is a presumptive TB case. Then go for the chest X-ray. Right sided highlight. You see the point at the back. Can you see me the, sorry, can't get the pointer. There's no pointer. There's no. No pointer. Okay, you can see the left side. There's a. You can see my indicator. Oh, sorry. So this is hilar lymph node. This is a hilum. You see the trachea, bronchus from the right bronchus. This is the left bronchus, and this is the hilar lymph node. And you see the adjacent, there's a consolidation, collapse consolidation. Because why it is collapsed? There's a sharp border, so it is collapse, and there's a homogeneous mass, that's a consolidation. How do you further evaluate this case? So this is a 4S symptom positive, is clear. Then chest X-ray, it is suggestive or not? Anyone? As I said, suggestive means either hilar lymphadenopathy, fibrocarditis type of tuberculosis, and malaria. So it is hilar pneumonia. That's suggestive. The sputum will go for the sputum. As child is 3 years old, we go for the gastric lavage or induced sputum if possible, and then send it for them and NAT for MTB. If positive, go for the treatment according to the test. If negative, then what to do? So checks is non-specific. In this particular case, it is specific, but if it is non-specific, give antibiotic. What antibiotic? Very simple antibiotic. Don't go for the high antibiotics. Amoxiclav or simple amoxicillin can be given for 10 days. And avoid giving fluoroquinolones. Don't give the fluoroquinolones and linezolids and all, because that can be used for tuberculosis. So give amoxicillin for 10 days and again repeat the X-ray. Persistent status, after 2 weeks you can have X-ray. See the X-ray, persistent symptoms and shadow is there or not. Then again you try to collect the sample from the sputum or gastric lavage and then send it. If it's turned to be positive, then okay, you give the treatment. But if it's not positive, even after giving antibiotic and all, think of the other disease and try to rule out other opportunistic infections. Third is the pleural effusion is there. Again, in pleural effusion, NAT is usually negative, 7% positivity, quite low positivity in pleural fluid. Go for the cytology, biochemistry, sputum, and other, even you are getting the pleural fluid, even though you have to collect the sputum, gastric aspirate, induce whatever the possible, how many samples you can collect, you try to collect these samples from different sites and go for the net and see whether it's positive or not. If MTB positive, then microbiology will confirm TB and treat. If negative, then you think of other causes and rule out the other causes, other opportunistic infection. It may be atypical microbacteria, it may be the mycoplasma, it may be the partially treated pseudomonas pneumonia and all. এটা চেঞ্জ হচ্ছে না কেন? Sorry, slide is not changing. I don't know.
Ma'am, click on the slide and then click on next.
Click on the slide.
Yeah, click on the slide and then on the keyboard next.
Can you see? I clicked on slide. It says wait, close the program or wait for the program to respond.
Okay. Can you stop sharing the screen? Can you do that?
Oh yes. Okay. Close the program.
No, ওটা হয়ে গেছে।
What happened? It's going on round and round and round.
Ma'am, I'll share the screen from my end.
Okay, so I should close the program?
Yeah, you can do that.
Okay, close the program. Yes, you just started. Can you share again?
Yeah, you can do that, ma'am.
Money, chalo aur ek glass dichi.
এটা একটু ক্লিক করে দিন। এটা দেখাচ্ছে।
Okay, bolish. Say that?
Yeah, ma'am.
It's not happening from this side.
I'll share it from my end, ma'am. Is the screen visible?
Yes, now it's visible. Okay. So can I go through?
Change the slide now.
Oh, just slide is changing. Okay. So should I start again from this slide? Hello, am I audible?
Yes, ma'am.
Okay. So we are here that X-ray chest. So chest is normal. In this particular patient, we had an abnormal chest X-ray, which is suggestive of TB. But sometimes you might get the chest X-ray normal. Check for extrapulmonary tuberculosis. Needs to detail investigation for TB, alternate diagnosis. May need CCT of the chest. Sometimes it may be diagnosed, picked up by the CT scan of the chest. And it needs contrast CT. So that the deep seated lymph nodes can be picked up. Other investigation as per the symptom suggest, clinically suggest, consider the referral to the higher centers for further investigation. So don't keep the patient over here. And if you suspect any difficulty, you can feel any difficulty, you can refer to the pediatricians. X-ray finding which are TB suggestive, as I already said, highlight particle lymph nodes, signs of endobronchial TB, that is fibrocavitary disease, and miliary mottling. Finding non-specific may be effusion, consolidation, bronchodilation, and any other status. Next slide. Next slide, please. Achha. Okay. So another case, a 2 years old newly diagnosed HIV positive child brought with a history of diarrhea with a fever of since last 2 months and failure to thrive since last 2 months. So is there 4 symptoms there? Fever, off and on, and weight loss. On examination, child is conscious, weight is 6 is 2 years, it should have 12 kg, 6 kg means 50% weight loss. Signs of severe malnutrition present, lethargic, not able to stand and support. So it's so sick he cannot stand. 2 years old child should run. Oral thrush is there, some dehydration is there, and there's generalized lymphadenopathy was present, and hepatomegaly was present. So the newly diagnosed HIV, these symptoms are quite similar with the HIV patient. Itself, without any tuberculosis, HIV child can have a oral thrush, lymphadenopathy, hepatitis. So, but if it is there, you always rule out tuberculosis. Does the child need hospitalization? Anyone? Because baby is not able to stand, and of course there is a severe malnutrition, so always go for admission. How to evaluate this child for abdominal TB? So you see there is a history of diarrhea and fever of it. So when there's an altered bowel habit, maybe constipation or diarrhea or persistent diarrhea, or there is a sometimes normal, sometimes there's a diarrhea. So altered bowel habit, always go for the suspicion of the abdominal TB. The next slide. Okay. It's already said severe malnutrition should be admitted to the patient. Yes, already serious because not able to stand and SAM child, if severe malnutrition, you are unable to treat, always refer. Today only I admitted one patient, 5 years, 5 years old child living with HIV, weighing 8 kg. 5 years should have been 18 kg and weight is 8 kg and looking like a 1-year-old child. Just now, today my admission is going on. I admitted the patient. So any severe malnutrition, you admit the patient. Seriously, a child needs immediate referral. Check for danger sign. What are the danger signs? It's very important. Always, that is called triage. Triage is a quick screening. Whenever the patient comes, always see the danger sign. Oh, it's not there. Then you ask them to sit in the OPD and see the patient. But if any danger sign, immediately refer to for the admission. So what are those? Not able to drink or breastfeed, vomiting everything, whatever you are giving is vomited out. Convulsion, lethargy, unconsciousness, stridor, or maybe you have some cyanosis, severe dehydration. These are the danger signs. Look for signs of severe illness like fast breathing, tachypnea, chest in drawing, or cyanosis there, sunken eyes, skin pigment, severe dehydration, high fever, stiff neck, bulging fontanelle, baby is drowsy, all those which, and this P2 SPO2 is a less than 90%. We immediately send it for the admission. Any child who has sign of being seriously ill should be referred to the appropriate facility for the management. Means indoor patient management should be given. Next slide. Now, how to evaluate a case of abdominal TB? So look for peripheral nodes, chest X-ray, abdominal. So when you're suspecting abdominal TB, it does not mean you will concentrate on the GI system. You always look for the other system also. It may be disseminated. As a part of disseminated TB, abdomen is involved. So look for the pulmonary TB, look for the CNS TB, look for the ostomuscular TBs and all any other parts of the TB. Then go for the USG. Now, whether USG is suggestive TB or not suggestive. Go for the, even if it's abdominal TB, go for the chest X-ray. If there's a peripheral node, go for the peripheral node treatment, as I've already said, FNSC or biopsy. Chest X-ray again, we have already discussed. And if there's a peripheral node and the chest X-ray is not there, if there's a ascites, you can collect the ascites, go for the testing. If there is any granulomas, you can take it, use the guided biopsy, you can take it. Lymphadenopathy, the abdominal mass is there. Sometimes the intestinal mass adhere to the momentum leading to the abdominal mass. You can go for the FNSC of that mass, or use the guided FNSC, you can do it, or CT guided, which is preferable in your center, you can do it. And of course, whatever the sample you are collecting, please send it for the NAT. And as I already said, if you're collecting the liquid sample, then it should be in the normal saline and send it in the Falcon tube. But if the solid, like when biopsy and all, it should be in the normal saline. There should be, you have to send the test for the center where solid materials can be processed. So they should have a crusher machine, that is called crusher. They will crush it and then dissolve it in the normal saline and they will go for the testing. So you should have all those information, or you can take the help from the DTO or STO. Then if there's any time that the test is microbiologically positive, accordingly you have to treat. Then USG of evolution, other causes, and go for the other USG suggestive, lymph node suggestive. In USG, what side? Okay, in USG, if there is a lymph node, we used to see the para-aortic lymph nodes and any other lymph nodes if the short axis diameter. We will say the short. Next slide, please. If you can say short axis diameter, it is there. Short axis diameter. If you see it is written suggestive finding when ultrasound. Abdominal lymph nodes measures 1.5 centimeter as a short axis diameter. So in the lymph node, there will be a long axis diameter, short axis diameter. So always write whenever you give the prescription for the investigation, you write the USG for abdomen to look the lymph nodes and please mention the short axis diameter. Others they won't write. So always write in a requisition form. Please mention the short axis diameter. So if it's more than 1.5 centimeter or 15 millimeter, or if there's a conglomeration or there's a central necrosis in the lymph node, is a suggestive of abnormal TB. Again, omental adherence, mesenteric thickening, bowel loops adhere to the omentum. They're all suggestive of tuberculosis. And thickening, again, if you can measure, always say please, if you think of Dowie, clinically you are getting the Dowie filling. When there's a Dowie filling, that means there's omental thickening. You can write in the requisition, please mention the thickening of omentum. Otherwise, radiologists are not going to write. So always mention all those things, what do you want to see from the result. That is more than 15 millimeter thickness, it is suggestive. Then, of course, ileocecal areas are very characteristic. Ileocecal wall thickening is the characteristic of tuberculosis. Non-specific finding you might get free fluid, loculated fluid, intestinal obstruction, either complete or acute obstruction, or short axis diameter less than 15 millimeter. And of course, go for the other tests like chest X-ray, sputum, all ascitic fluid, peripheral lymph nodes, whatever the sources are there to get the sample. Now, if ascites is there, it is exudative or transudative. If exudative, go for the NAT. And don't go for the ADA. Usually, in previous days, everyone used to do the ADA. ADA will say it is viral or bacterial. They won't differentiate from bacterial to tuberculosis. Enlarged abdominal mass, if there, you can take the biopsy from that. Desirable is USG guided abnormal mass FNC. Already I said, if you have a USG guided or CT guided, you can go for the biopsy of the material. Which, as you said, you can do the omental biopsy also. Intestinal involvement is there, then the CECT can the enterography can do by dye. USG guided abdominal mass, say you can take the for if any cytology, or you can give the biopsy also and send it for the culture, and both NAT and culture to be sent at a time. Or sometimes you can do the endoscopy like ileocolonoscopy, and where you can get the biopsy. A laparoscopy or tissue biopsy for HP, or depending on the upper GI or lower GI, you have to go the endoscopic finding. Next. Another case, 7 years old newly diagnosed child with HIV. She has come with a history of multiple swelling of her neck and armpit, that means generalized lymphadenopathy. Fever often since about 10 days. Weight is 19 kg, quite low. Height is 100 centimeters, so shortest stature, because 7 years means should have been 21 centimeter. Vital stable, oral thrush is there. So, numerous posterior cervical lymph nodes, pulpal, varying size between 1.5 to 2 centimeters. So that means significant lymphadenopathy is there. A swelling of matted lymph node, that's a characteristic of tuberculosis. If it is matted is there on the right axilla, and size is quite large, 3 centimeter by 2 centimeter. Organomegaly is present. Other symptoms, no adenopathy detected. Is she a presumptive TB cases? Yes, it is presumptive TB cases. Not present clinically diagnosed case TB cases. How do we further evaluate the child for TB? So generalized lymphadenopathy, next slide. Generalized lymphadenopathy, go for the FNAC. If not, if they give inconclusive result, you can go for the biopsy. And then you can go for the chest X-ray also. And as there is a hepatosplenomegaly, you can go for the USG of the abdomen to see the liver ecotextus and splenomegaly and any granulomas there or not. Okay, next slide, please. Next. Next slide, please. Yes. So swelling lymph node, already said, fine needle aspiration will do. As this is already discussed, extrainguinal lymph nodes more than 2 centimeter, asymmetrical lymphadenopathy, tender painful lymph nodes usually due to the local infection, not because of tuberculous lymph nodes are usually non-tender until unless there is a FNAC done prior and you have examining after the FNAC, then it will be tender. Matted, fluctuant, of course, is characteristic of tuberculosis. Hilar mediastinal lymphadenopathy on chest X-ray. Even sometimes you can go the USG chest also to see the mediastinal lymphadenopathy. Significant retroparental lymph nodes in USG, evidence of abscess like cutaneous abscess, pulmonary, any other sources from head to toe you have to look for. Remember to send the FNAC sample for NAT and AFB and a histopathological examination. Lymph node biopsy may be necessary for definitive diagnosis because sometimes FNAC is not conclusive. Next slide, please. So standard treatment workflow, as I've already said, pediatric lymph node when to suspect persistent enlargement. This is all discussed without if there's a lymphadenopathy cannot be explained any other disease, always go for if it's acute lymphadenopathy, rapidly enlarging, painful, tender, maybe acute viral infection. But painless, quite long, gradually increasing, matted, sinus is there. These are very characteristic of tuberous lymphadenopathy. No evidence of local infections. If there's a local infections, draining lymph nodes will be enlarged. Suppose in the cervical lymph node, if there's a otitis externa, if there's a infection in the scalp, if there is any infection in the skin of the back of the neck and back, it can drain to the lymph nodes and can have a acute lymphadenopathy. So rule out the local infections and then think of the tuberculosis. And if it is the cold abscess, means there is an abscess which is not having the signs of inflammation, and that is called cold abscess, and the characteristic of TB. If there is a discharging sinus also, you must rule out TB. Investigation again, same as I've already said, lymph node aspiration, go for NAT and MGIT culture, or not possible, then go for the biopsy. So desirable is a lymph node cytopathy, lymph node cytopathology, histopathological examination, microbiological examination for NAT and MGIT, all three to be done. So don't forget to write HPE examination also. A lymph node biopsy, chest X-ray should particularly be done if FNAC is not possible, or of course you go for the other routine investigations like chest complete hemogram with the peripheral smears and other cytopathology if required. Okay, next slide. Peripheral lymph node more than 2 centimeter. Okay, so if now the X-ray is there, lymph node is there in last, what to do? Go for that pulmonary, rule out the pulmonary TB. I'm not going to line by line because quite 3 p.m. is already crossed. So can you continue for 10? I think last slide we have used.
Yes, ma'am. Should I go back to the previous
Yeah,
slide?
back previous slide. Okay, so if the chest X-ray, even though the lymph node is there, no respiratory symptom, go for the chest X-ray and see it is suggestive or not. If suggestive, then as we have already discussed about the flow chart, we'll go in that. If not suggestive, then again we go for the lymph node. See the lymph node whether it is a matted or discharging sinus or cold abscess. It is suggestive of tuberculosis. Then go for the FNAC or HPE examination, one means histopathological examination, FNAC, smear and culture. Now all the cases you have to send all three. If it's not suggestive of tuberculosis, not matted, it is non-tender, it is tender, or there's no discharging sinus, think of bacterial origin. This is quite common in pediatric school, especially in HIV patient. So go for the simple antibiotic amoxicillin and give it for 7 days. So antibiotic amoxicillin or amoxiclav are recommended, and don't give the linezolid and quinolide as we have already discussed in pneumonia. Similarly, in the lymphadenopathy also, give for 7 days. There we ask for the 10 days and review the case after 2 weeks, whether the size is decreasing or not, or the other symptoms, constitutional symptoms are improved or not. Even after there's no response, size is same, go for the excisional biopsy and send the investigations for NAT, culture and HB. AB on the smear it can be seen. If there's a granuloma, go for the granuloma tissue to be sent for the smear and culture. And if possible, it can go, if a smear is not positive, if any signals, we can go the excisional biopsy, total biopsy, excisional biopsy, and send it for the culture and NAT and histopathological examination. Next slide. Next, criteria for diagnosing the DRTB. So when we suspect the DRTB, drug resistant TB, if the child is come in contact with the DRTB, is close contact the person who died while on TB. Patient of TB, HIV died of TB, you think of the resistant TB. Close contact the person who failed the TB treatment. Means the relapse or recurrent TB and maybe a child has come into contact with us. Those persons should be considered as a DRTB, and you have to rule out the DRTB. Non-response or failure of the first line treatment. Previous treatment or second line medication. And one extra point I would like to ask, if there is a DRTB in that particular area and the baby child is belong to that particular region, we always think of DRTB. So area also very important. If the patient is coming from that area is having DRTB, and child is coming from the same particular area, think of the DRTB. Next slide. Okay, I think this is the last slide. So if there's any question, I'd love to see. Is there any more questions?
I'll
Okay.
check, ma'am.
Yeah, there's no.
There was one question in the
But
chat box.
yes, is BCG vaccines are required in children? If yes, when? Yes, very good question. We know the child living with HIV, if there's a horizontal transmission, that means after the birth that it will take long time to be immunosuppressed, and before that you have already given the BCG. So at birth you are giving the BCG. But if it's a vertically acquired HIV, child is vertically acquired HIV, so we know the maximum transmission takes place at the perinatal period. So if the baby has acquired the infection during transport, during the perinatal period, it will manifest after few weeks. And you are going to give the BCG at birth. At that time, baby is not severely immunocompromised. So each and every child, exposed child whose mother is positive, who must give the BCG vaccination. But if any reason, suppose baby is delivered at home and baby didn't bring to the hospital and you didn't give the BCG on the first day, then the next BCG can be given when baby is just asymptomatic and CD4 is quite high and all, within 1 year. Before that, we cannot give it. So BCG is not given in the at birth. You cannot give it as such. You have to see the other features, whether the baby is positive or not. If in this particular case you have written the child is living with HIV, means child is diagnosed case of HIV at what age? Because BCG is given at birth. So if baby is not diagnosed HIV at birth, so must be diagnosed later on, and already BCG should have been received. But if baby BCG was not given, and now the baby is HIV turned to be positive, we don't give the BCG. See the response, see the viral load, CD4, other clinical symptoms, clinically, immunologically, virologically stable, then you can give the BCG. But it's not recommended above 1 year by Government of India, and by Indian Academy of Pediatrics, BCG can be given up to 5 years, not beyond that. So if 6 years old, you are not going to give anyhow. If from the private and from the government, more than 1 year, you cannot give the BCG. This is the one question. Any other questions?
Yeah, in USG, what size
Yeah.
of lymph node is suggestive for TB?
I
How to
already said
differentiate?
how to differentiate lymphoma also. Okay, so in lymph node suggestive TB is already said, you always go for the short axis diameter, and the size of the diameter should be 1.5 centimeter or 15 millimeter. This is the lymph node size. And other suggestive fibers like ileocecal thickening, omental thickening more than 15 millimeter. There's a subject obstructions, omental biopsy, and other suggestive go for. But case of lymph node, short axis diameter should be more than 15 millimeter. And how to differentiate from lymphomas? Yes, because it's very confusing. In lymphoma also they present usually present with a non-Hodgkin's lymphoma. Hodgkin's lymphoma is quite in the older children, adolescent, not in the younger children. Non-Hodgkin's lymphoma can be affected. Children can be affected with the non-Hodgkin's lymphoma. There will be a generalized lymphadenopathy, and in tuberculosis also there may be a generalized lymphadenopathy. So in FNAC, it is very difficult to differentiate. Sometimes you might get the type, but it's not possible to get. Then you go for the biopsy. And we have seen, because it's a tertiary care and lots of referrals patients is to come in our center, we have seen even it's very difficult, even it's not able to differentiate by biopsy also. And we had to do for the IPT, that is called immunophenotyping. Sometimes we do go for the biopsy and phenotyping to see the whether it is lymphoma or tuberculosis. So you can, if you get the you have to see the child in a toto, in a comprehensive manner, not only the lymph node. So if the child is having generalized lymphadenopathy, hepatosplenomegaly, and peripheral smear is showing abnormal lymphocytes, so go for a complete hemogram and differentials, abnormal lymphocytes. Then if you see some abnormal lymphocytes or some characteristic giant cells are there, so that will differentiate. But if it's not possible, then go for the biopsy. Even if it's not confusion, go for the IPT. Thank you. Any other questions?
Ma'am, there are no questions in the chat box. Kiran sir, can we please give mic access? Requesting
Madam.
participants. Yeah, yes, sir.
Myself, Dr. B.N. Tripathi from Bhubaneswar ART Center, Odisha.
Yes, yes.
My question was about this BCG vaccination. Actually,
Yes.
there is a lot of noise over here. I could not follow what you told about that. Please
Okay, I can repeat it. First, you said that BCG can be given in children living with HIV or not. Okay.
Right, madam.
It is, yeah. So I said it is if the child is positive in a horizontal movements acquired after birth. If baby has acquired HIV infection after birth by blood transfusion, by operation, by whatever mode, not by vertical transmission. Clear?
Okay.
So baby has already received BCG at birth. So there is no question of BCG giving in. And Government of India said by NIS schedule, National Immunization Schedule, BCG can be given up to 1 year in a normal child. I'm talking about, not in HIV. So if you not given the BCG at birth in a HIV positive child, because HIV positivity will be if vertically transmitted, first testing to be done at 6 weeks. Am I
Okay.
clear?
Right,
And
right.
before that, we have given the BCG because BCG to be given at birth.
Right.
And the diagnosis to be done at 6 weeks. So before being positive, HIV positive, baby already received BCG. Clear?
Okay, okay.
And there is no immunosuppression because maximum transmission takes place during the perinatal period. So it will take the time to decrease the CD4 viral multiplication. It will take time. And so baby is not easily immunocompromised at birth, and you can give the BCG at birth. Even HIV exposed baby, they are not positive or negative. Exposed baby means the mother is positive, but
Right,
baby
right.
status not known.
At
So,
birth, the status is not known. Okay, okay.
so at that time, you jolly well can give the BCG at birth. Clear?
Okay,
And
okay.
at 6 years, you're going to do the testing, DBS testing for total nucleic acid testing, baby is positive, negative. So if vertically transmitted child, they are going to be positive or negative are to be detected by 6 weeks or 6 months or 12 months or whatever the protocol we have.
Right, madam.
Am I clear? And before that, you have already given the BCG at birth. But somehow it is missed. ऐसा हो ही सकता है ना, somehow it is mixed.
Right.
Baby is not given a BCG at birth. Then you 6 weeks you have tested, child is supposed is negative. You can give it. But
Okay.
if suppose baby is positive, clear? Two situations, baby is positive or negative. Suppose baby is positive, then you see these signs and symptoms, how far baby is immunocompromised, like viral candidiasis, hepatosmegaly, fever. Then you go for, don't give the BCG, you go for the CD4 and take the child with the things and see the CD4. If CD4 is more than 30%, then you can go to BCG. After giving the treatment, baby is stable, CD4 is quite high, then you can BCG, but below 1 year. Because BCG as such is recommended below 1 year, not above 1 year by NIC. Am I clear to you?
Right, 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 madam. Very
Okay.
clear. Madam,
Okay.
one more question. It is, of course, not fitting
Pardon?
the this topic. In adults, is BCG vaccine given in adults?
Yes. There are studies going on, and in Delhi also, in our state also to be started, because for to prevent the LTVI, latent tuberculosis bacilli infection. They are on a study mode. It is given in the BCG vaccines going given in the adult persons to see the decrease in the transmission of TB to prevent the LTBI. That LTBI means latent tuberculosis bacilli infection. वो
Right.
study में हो रहा है, and sometimes there is some study to prevent the bladder cancer and all. This is the other indication for giving BCG therapy. Not in pediatrics, not in HIV.
Madam, you told that it is in study now, not now implemented.
Which one? Not implemented. It is a study. Delhi already started, and in I think in West Bengal also four districts are picked up, and they are going to give the BCG as a trial mode, pilot
Right.
mode, pilot mode.
But it has not come in mass to give
No, not not in immunization schedule
policy,
by
as a
government of India.
vaccination policy. Okay, okay. Okay, thank you. Thank you very much.
Thank you.
Any more questions? Participants can unmute. Ma'am, we'll quickly run the feedback form meanwhile.
Yes.
Kiran sir, we can have the feedback form. Thank you. The feedback form is now visible on your screen. Participants are requested to please attempt the feedback poll. You can scroll through all the 5 questions and click on the answer of your choice. Please read the last question carefully. Requesting all the participants to please attempt the feedback poll. Thank you so much, ma'am, for facilitating this important session.
Okay, কাল সকালে
Thank you, Shweta
কাল
ma'am.
সকালে আমার চেম্বার
Thank you, thank you. Thank you to all the participants for patient listening. Please attempt the feedback poll before leaving the meeting. We'll wait for another 2 minutes.
নাড়ালেই চলে যাচ্ছে।
I think participant can write in the chat box or in the mail. What do you want? What type of sessions you want? That will be useful for you people only, no?
Right, ma'am. Requesting participants to please put it in the chat box, the topics that you would like to be addressed during the RDLS session. So those topics can be taken up for these sessions. So any particular topic you would like to have more information on, you can please write in the chat box. Programmatic as well as technical. It's not only the clinical topics, even the non-clinical programmatic topics can be taken up in the RDLS sessions.
I think all have answered 100%.
Yes, 62%. I mean, 20 people have
There
answered
is,
the
oh,
feedback
it's
poll.
20 by 20 is written answer. That's it.
Yeah. Ma'am, we'll try to get the topics through SACS,
Okay. Take it.
right? Okay, ma'am.
Thank you.
Thank you so much, ma'am. Thank
Thank
you
you.
to all
Thank
the participants. Kiran sir, we can end the feedback poll now. Thank you, ma'am.
Thank you.